Hi, hi. Good morning, everyone. Um, Thanks for getting up early and be there, and including me, many of you who were there at the lovely dinner. I think it was a bit of a push to get up and come, but that was a great evening, and I thank again Peter and the organizing faculty for inviting and hosting and giving the opportunity to contribute to this very prestigious meeting. So I think the talk, or rather the tutorial for this morning, is something that we deal with on a day-to-day basis, and clearly it is one area where we have more about physician-based medicine rather than evidence-based medicine. Uh, can I just request to have the lights slightly up? We don't need dark room. Yeah, thank you. Yeah. So before we start, I think the question to ask is, how many of you are following any set guidelines about escalating the inotrope or vasopressor therapy on your unit? Okay, excellent, thank you. Are there any burning questions that you think that we could discuss during this session and find an answer to that? Maybe any one or two questions that come to your mind? Anyone? Fair enough. Not to worry. I think as we move on, we'll probably get charged. So we know that one size does not fit all. And the spectrum of babies that we have range from extreme premature babies, managing pulmonary hypertension, HIEs, surgical, cardiac, hypovolemia, septic shock, and you name the situation. We also realize that no two babies are same, and the management, it differs based on the condition of the baby, right? So for this talk, for the next 30, 40 minutes, what we will do is the aims and objectives will be a little bit of the physiology and the impaired perfusion, and then how do we choose the inotropes, and what approach we adopt, and as I said, it is more about physician-based, but over the years, how have we integrated the various techniques, tools to base our management of circulatory failure. And we'll discuss maybe 3 or 4 specific situations and what is a more likely consensus statement or approach in managing those babies. So we are going to talk on these lines for this talk. We know that pressure is a product of the cardiac output and resistance, right? And if you look at this, the flex starting curve here, it is A, which is the center, B is where your end diastolic pressure increases, but your stroke volume is not increasing, and the C is where your even a mild increase in the LV end diastolic pressure, the stroke volume goes up. So the question is, when we intervene to increase pressure, we may increase the flow, and we know that. We may also increase resistance at times, and we see the situation specifically when we potentially shift the Starling curve to the right as a situation B, and that will impede the cardiac output. So this physiology never goes away, and I think it is nice to keep in mind that what can happen by changes in the pressures. We also need to remember for our bread and butter, which is the preterm babies, about the preterm myocardium, how is it different from pediatrics, from adults, and because primarily it is structurally very different. We know that there is lack of sarcoplasmic reticulum and the T-tubule system in there with shorter myofibrils, right, which are more round and more randomly oriented. So for the same impulse, the contractility is not the same. There is more fibrous tissue, and myosin light chain 1 is higher, that is more in the last decade. There is decreased sympathetic innervation and fewer adrenoreceptors with this immature myocardium, hence is more prone or more sensitive to changes in the afterload. And that is a very important point here, because when we manage our babies, and as you would see, we have probably got away with dopamine in preterm babies for last about 15 years. Don't use them at all. And the reason is primer first line, as until we know that the Cochrane review, which was 2003, also said first line dopamine. Studies in preterm babies have clearly pointed out, and the work from Nick Evans about it, that you increase the afterload, preterm myocardium can't cope with it, and the output decreases, which is not good for the baby. Okay. Now, this is a very common schema, which maybe you would have seen or used in various different forms. Essentially, what is here is the systemic vascular resistance times cardiac output is the blood pressure, right? Now, why is it important? Because cardiac output, it leads to the target organ flow, which leads to the oxygen delivery, which is our DO2, the whole reason why we are looking at the circulation. Second is about the hemoglobin, very important, maintaining appropriate hemoglobin, more so in babies with cyanotic heart disease. And it affects the blood oxygen content apart from the oxygen delivered via whatever respiratory support, FiO2 you are using, and that is also affecting the DO2, which in turn affects the cellular metabolism. Now look at the cardiac output, heart rate, contractility, preload and afterload. So all of them are primarily affecting the cardiac output. When you look at the heart rate, it is also been known that the babies, newborn babies, they essentially change their stroke, they can't change their stroke volume, so they change their cardiac output by varying the heart rate. So the heart rate babies would try to increase, but we also know if the heart rate goes up, that is tachycardia, now we understand it is not good for the baby because it causes diastolic dysfunction in these babies. And hence, we need to give enough time to relax for the heart to fill before it pumps out. Tachycardia, never good for the babies, whatever we do, yeah? Okay, so the question is, how do you routinely assess perfusion in newborn infants? Any pointers? Okay, let's move for the sake of time. This is a survey that was done in Europe, and the question was, a 6-hour-old baby who's born at 25-week gestation with a mean blood pressure of 23 millimeters of mercury, stable on mechanical ventilation with a MAP of 9, how would you evaluate the perfusion in this baby? So the return of 216 questionnaires, and I think we all can probably align our practices with what we see here. And you can see very commonly used capillary fill time, urine output, heart rate value, peripheries, base excess, lactate. All of this very commonly used, and less so the ones which are at the bottom. But this is the clinical assessment of these babies. So if we just use them and divide into 5 different sections, and what are the 5 different sections here? I think it is important to look what is the pump, that is the heart. So the heart rate reflects that. Afterload is the arterial or the capillary bed, which is the pulse volume. Capillary, we need the capillary fill time. And organ perfusion, urine output, skin color, core peripheral temperature difference, lactate. Very, very commonly used, and we use on a daily basis. But if you take a step back and think, when does all of it change? It changes quite late. That means when a baby moves from compensated state of shock to uncompensated state and then irreversible state, right? So when the baby has already gone from compensated to uncompensated state, that is the time you start seeing changes in the end organ perfusion. Is that the right time? No. We could have intervened early, and I think more impetus is now on picking up babies and treating while they are in a compensated state of shock. Next is about the veins, and unfortunately, on the neonatal units, it's very hard to measure the JVP. But you go to PICU, this is a normal CVP measurements. And we have tried to look into the CVP measurements because of the ventilation, because of our size, because of the difficulty in placing the cannula. It is very, very difficult to appropriately monitor the CVPs. Otherwise, to assess the preload, this is the fantastic way of assessing. Just touching upon briefly upon various things like the color, and this is the Mallet study that was done from Melbourne, Australia, and what it says that when the baby's the skin was masked and the saturation monitor was masked in there, and they were shown what do you think is the saturation, and the numbers in 20 different babies, it could vary as much as in the same baby. It could be saturation of 40% to 100%. So eyes are not good enough to assess what the color is. So is it a good marker? Possibly not. We can't just depend on the color, but we make our bedside decisions very commonly on using this. We know about the limitations of heart rate, capillary fill time, core peripheral temperature difference, and the urine output, because I said they are all late. And capillary fill time, a good marker, anything more than 3 seconds. Some people take, the specificity is much higher if you're taking more than 5 seconds, but there is very little relationship between the systemic blood flow and the validation is very less, okay? Okay, This is work from Dr. Martin Kluckow, and I think it was the initial one, which was started from the SVC flow, that can we relate the SVC flow with the markers that we are looking at the blood pressure. Here we are, I'm projecting about the left ventricular output and the mean blood pressure. If you have a LV output, minimum 150 mils per kg per minute, that is the minimum normal. Your range is 150 to 300. Your mean blood pressure for a gestation, that is about a preterm, which is 30 weeks or so, is 30. If you look at the crossroads here, anything up in the upper quadrant is good, because good flow, good output. Anything which is in the lower is again good output, the blood pressure is low, you need to monitor this baby. You come on the left upper quadrant, that is a worry. Your blood pressure is normal, but your output is low. And this raised a concern in preterm babies that we should be looking just not on blood pressure, but on other markers, that what is the flow like. So the limitations of current practice are the clinical science used at the bedside to detect perfusion impairment is quite late. Mean blood pressure is used widely. It, however, reflects perfusion pressure, but does not give any information on the arterial pump, which is heart, or the vascular resistance, that is diastolic pressure. So I would urge you that on your units, whenever you are rounding, yes, the practices on the BAPM criteria have been to look for the mean blood pressure, but please do ask what is systolic and diastolic pressure, because that is going to give you more information about the underlying problem, what is happening in the baby. And we have used a regimented approach rather than the physiology-based approach. And that was what I said at the start. Our babies are different, and they come at different scenarios, different background, and the problems. And I think looking into each of them, that's what we'll do in the next half an hour. So one of the things which started coming up in the last decade or two is about the bedside non-invasive assessment methods to assess perfusion. And this is just on the same line: preload, function, afterload, capillary perfusion, and organ perfusion. I described two things: non-invasive functional echo, increasingly adopted, increasingly utilized, and I think in a sick baby, and it showed that to manage a baby without looking at the heart is probably in the dark. We are trying to find the answer. So SVC flow, still some people use it, but there is a limitation about this SVC diameter measurement, and because of that, there is a bit of a limitation because the variations can be quite high. So if you are good at it, please do it. IVC pulsatility and diastolic LV and RV volume, that can give a good preload assessment. Systolic and diastolic function can be assessed using the echo, and it has gone too far. There are indirect markers of echocardiography, functional echo, where we look at the cardiac outputs, or we can go for a specific markers like what if you have attended yesterday's session on the pulmonary hypertension. So right ventricular function can be assessed using TAPSE, left ventricular ejection fraction, fractional shortening. Even you go further, you can use tissue Dopplers and look at the various criteria for looking into the S prime and look at what the height of it. You can look at the diastolic function, looking at the tie index. So it is going forward. You take a step further forward, you can do the spectral tracking. And spectral tracking gives you a segmental contraction of the left ventricle. Now it has started coming for the right ventricle also. So, depending on how much your interest is, how far you want to go, and in certain situations they become useful. But the basic assessment is always very helpful, I find. Then is a non-invasive other methods, which is ICON or electrovelocimetry, or you would have seen here the USCOM, which is again a non-invasive cardiac output monitor device, which is there on the display and kindly supported this conference. We use the ICON, and there are a variety of parameters which could be done. Also, there is the pulse oximeters, which can give you a pulsatility index, and it is a marker for the capillary perfusion. Now, the word about the ICON. So this is a simple device which works on the electric velocimetry principle. We don't have time to go into details, but this has a number of things. So it gives you, instead of a point assessment, a continuous assessment of the stroke volume, of the cardiac output, of the, you can take the blood pressure and spits out this systemic vascular resistance. It can give you information about the preload. And on our unit, at least 20 ITU beds are equipped with this and are used on a regular basis. We did some time ago a work on correlating that how does it look at it. And this was a serial assessment in babies where we looked at the heart rate, cardiac index, stroke volume, index of contractility, and thoracic fluid content, and how did it change over the period of time. When we looked at the cardiac index and compared to the electric velocimetry, you can see it is not completely transferable. It does not mean that what cardiac output it is giving is what you will assess from the functional echocardiography. What you would see here is in blue is the CI, which is the cardiac index using ICON, and this is the left ventricular cardiac index, and this is the right ventricular cardiac index. So it is a trending phenomena. You do the first echo, you find out where is your ICON value for this baby, and then it gives you a nice trend without time doing the echo again and again and again to assess that. And the same thing, we see the comparison of the fractional shortening and with ICON and using the functional echo. So there is a correlation. It's a good continuous trending mechanism, but does not replace functional echocardiography. This many of you might be part of the SafeBoost trial, and this is GOM's work apart from the organizing collaborative group in there. A great schema tested in this SafeBoost 2. Now I think it is just completed the 3, and they're presenting or publishing it, where they looked at the RTSO2 of 55 to 85, anything below 55, brain perfusion not good, and they assess based on what these problems are found and take the action. If it is above 85, that is what they do. So this is one of the first moves, and it clearly showed in the SafeBoost 2 that it does show or reflect upon the cerebral saturation and the outcomes based on the hypoxia on these particular babies. We won't have time to go into the details of the functional echo, but there are a lot of resources available, and the courses are every now and then organized. If you're interested, please get in touch. This is just a schema about if a baby is hypotensive, you do the echo, what do you find? You find a low cardiac output, or you find a normal or high cardiac output, a starting point. Indirect measures, easy to do, and you can have a starting point. Based on the low cardiac output, you can see if there is an impaired contractility or there is a hypovolemia. Two things, very common. Impaired contractility, clearly you go on the inotropes. You have hypovolemia, you give volume expansion, right? You have a normal or high left ventricular output, there could be a PDA, which we know we have to treat the PDA. If there is no PDA and it requires a vasopressor, again, the dopamine is here, we don't use it, we instead use a low-dose epinephrine. Persistent hypotension comes in there. We'd go for volume expansion, hydrocortisone, and escalate the treatment as it is. Now, this is just a guide, a schema, to have a broader picture, where to start and how we proceed further. The question comes now is, how do we select inotropes in infants with impaired perfusion or shock, right? And this is where we go back to the physiology again, to see what actually the inotrope does, or what does the vasopressor does, right? Before moving on, I think we all would agree that we need to first have a decision that what are we dealing with? Are we dealing with a hypovolemic shock? Are we dealing with a cardiogenic shock, or a distributive shock, or an obstructive shock? Because the initial diagnosis will guide what you would want to do in sequence so that you do no harm in these babies, okay? Now we have choice of inotropes, and we have been using traditionally, if you look, and that is a bit of a difference that used to exist a lot more about 10, 15 years ago between CICU and the NICU, that in the NICU, we were comfortable using dopamine, dobutamine, full stop, right? Going anything beyond that, epinephrine, once in a while, I have a courage, I use that. Milrinone, still we are very afraid in majority places. Vasopressin, new kid on the block. Levosimendan, still very little experience. Steroids, time and time again we use it. But when do we use it? So I think just a step back and see what does each inotrope does. Before moving that, just clarity on the inotrope, lucitrope, and vasopressor. Inotrope increases the myocardial contractility, right? Lucitrope, it relaxes the myocardium, very important. And this is important in babies because the relaxation of myocardium decreases the oxygen utilization and improves the cardiac function. Vasopressor, in babies with a decreased systemic vascular resistance, you use a vasopressor because it increases the vascular tone. Simple schema, again, you would have seen a lot of times. Receptors, Alpha-1 receptors, they are present on the vascular walls. Stimulation causes vasoconstriction, right? Adrenergic receptors, beta-1, beta-2, beta-1 present in the heart, increase in cardiac contractility, and stimulation also increases the heart rate, right? Beta-2 receptors present again in the vascular bed, which decreases the resistance, and that is where the epinephrine starts working on a low dose. It causes relaxation. We have dopamine receptors, which are present in the splanchnic bed all over, and we know there has been, in the low dose, dopamine improves the renal flow, which is still a concept which prevails. Mechanism of action, all these inotropes listed, and these are this is the work from Dr. Esteban Seri, which has been more than about 15, 17 years old, but still a nice schema of seeing what is the severity of it. But what I've done is, for the ease of translation, I changed this into this particular graph, right? Because we use on a bedside on a day-to-day basis, and what does it say? On the x-axis, on the right of the line is a drug causing vasoconstriction. On the left, it is causing vasodilatation. On the vertical line, this is increasing contractility. If you look at the epinephrine, in a low dose, say 0.02 microgram per kg per minute, it causes a degree of contractility and causes vasodilatation. But if you increase the dose, it starts causing more vasoconstriction, right? Second, dopamine, again, it has no vasodilatation but contraction. If you look at dobutamine, at a 5 microgram dose, practically no effect on the systemic vascular resistance. But as you increase the dose, you can get vasodilatation, but it improves the contractility. Isoproterenol, you see the vasopressin down here. Very minimal effect on the contraction, on the cardiac contraction, but it causes vasoconstriction, apart from decreasing the pulmonary vascular bed pressure, right? So having this kind of a schema in your mind will help in selection of the inotrope as actually what do you want to do. We decided what kind of shock it is, we know what the inotropes do, and now it becomes easier to select what we want to use. So this is from Willem de Boot, and the various drugs, the vasoconstriction, inotropy, vasodilatation, combination of inotropy and vasoconstriction, and inotropy and vasodilatation. So these are the inotropes which you can group in these particular different compartments to use it and utilize it as and when required. So the point comes to is about inotropy and precision medicine. That is what I was pointing to, that when we start, we don't have the time for going into the evidence, and that's why I have not used it, but I put it on the slides after the end, so you can access it afterwards if you want to look at what the evidence is, right? But it is, whatever the trials have been done, we can't group the babies into one and see the effect of the intervention. So the precision medicine, when we want to bring in, again, it comes in to start with the diagnosis. What are the hemodynamic problems? What do you want to achieve? And that should be the starting point. And how are you going to achieve with the inotropes and vasopressors? Clearly, before you start, it is important to be clear in mind, what is your success criteria, right? So you want to say, okay, I want to increase my blood pressure of 5 points. Okay, that is your success criteria. I want to increase my cardiac output. That is the success criteria. Sorry about that. So we need to avoid the inotrope soup. What it means is, invariably, we have a sick baby. We start with one inotrope. Baby is not getting. Second, third, it's not infrequent. And we all would have seen, at times you go on the round, the fellow has already started, and baby is on 4 inotropes of vasopressors. Becomes difficult, because weaning that down is very difficult, because you don't know what was the point when this particular drug was added. And I think there comes the teaching about justifying and documenting why was this added, so that it becomes easier to retract when it is required. So I'll touch upon the systolic and diastolic hypotension now, and how would you manage it. And I think this is some work which has been done by Reagan, and it's quite an interesting publication with Patrick's group. So this is what are the factors that contribute to the low cardiac output. Okay? You look at the low blood flow and impaired filling. They both reduce the preload. And these are the various causes listed in the box which can cause the low blood flow, the pulmonary blood flow, or impaired filling of the left ventricle. Here comes the reduced contractility, a rhythm problem, arrhythmias, or a congenital heart defect. They both can lead to this, or a myocarditis, or asphyxia, and all of this can cause it. You come on to the increased afterload. There is a failed adaptation and vasoconstriction for a variety of causes which can cause this. Now, taken all together, what it will do, it will reduce the cardiac output by the mechanisms we have talked about it. So that's a low cardiac output state, and that will cause your low systolic blood pressure, right? So what is our approach to the systolic hypotension? What should we do? We need to first manage the non-cardiovascular factors for low filling. For example, you have a baby who was not oxygenating well, and you started on say, high frequency on that baby. So you were on a mean air pressure of 12. We know that there's somewhere about an arbitrary cutoff of 12. Once you cross 12, it does start affecting the preload. So your baby was not oxygenating well, you start increasing the pressures. Now what it is doing is, it is increasing the pulmonary vascular bed pressure and also reducing the venous return into the heart because of the closed cavity. So what do you need to do here? You need to optimize the ventilation because that might not be the primary cause. The primary cause could be at the cardiac level, and what you need to address there. Secondly, you need to justify hypovolemia and administer fluid bolus, because if the baby is hypovolemic, it won't respond. And it is not good to whip a tired horse. That is, if the baby is hypovolemic, you increase the inotrope, it causes tachycardia and does more harm and increase the lactate. Consider dopamine initially in systolic hypotension or a low-dose epinephrine, and see if the baby should not go tachycardic. If the baby gets tachycardic, you need to think about the strategy and see to bring the dose down and add another agent, because tachycardia, as I said, is not good for diastolic function. With associated hypoxemia, always think that, are we dealing with the PPHN situation? And in those situations, you can consider reducing PVR, and we'll talk about it. Milrinone is a good adjunct, and we have found it very helpful in particular disease states like pulmonary hypertension, in certain post-operative cardiac states, and hence one has to be a bit more confident, but use with caution in babies with HIE because it can accumulate and it is very difficult to get rid of it in these babies. Never give a loading dose of milrinone with systolic hypotension in babies with hypothermia, right? Vasopressin, it decreases the PVR and increases the SVR, right? Make sure in this situation, if you are using vasopressin, that the cardiac function is not impaired, because if it is, then you won't get the desired effect on these babies. We know now, that is something new that we have also learned from the cardiologists, that the right ventricle is more important, it's very important, and sometimes it can drive the low blood pressure and the low cardiac output. So a significant LV interaction is there, and we see that in pulmonary hypertension cases, when there is a dilated right ventricle, it can press upon the septum and decrease the left ventricular cavity size, which will ultimately decrease your left ventricular output. Systolic RV function, it responds much better to inotropes and responds to pulmonary vasodilatation, because if you decrease your afterload from the pulmonary bed, your output goes up. RV diastolic functions need some attention, and failing RV is very sensitive to fluid. So if the right ventricle is failing and you give a fluid bolus, you make the things worse. Because of the wall stress, if the wall stress increases, then it starts affecting the function and the output. In this situation, when there is RV dysfunction, milrinone is a drug of choice, and I think it goes without doubt. You start a low dose, 0.3, and you immediately see the effect. Monitor RV at the systemic pressure, because what happens is, in situations when the RV starts failing and you have time that the duct is still there, which we have an advantage in our specialty, we tend to start the inotrope, and the RV is not improving in babies with pulmonary hypertension, with underlying hypoxic state, or a preterm baby even. We tend to see, can we open the duct and offload the RV? That gives time. Because if the RV is offloading at the expense of right to left shunt, we get some time, and that time the heart can recover and we can get back to normal. If you do not open the duct, we are stuck because the RV will not pump against the higher PVR. If we can't pump against a high PVR, the RV will fail very quickly. This is very commonly seen in babies who are severe symmetric IUGRs with a PPROM for weeks, delivered, and they are okay in the first 1 or 2 days' time. Day 3, they start manifesting with hypoxia, pulmonary hypertension. And that is a specific situation we find where if the baby is salvageable, I am sorry to say that, but then Prostin is very helpful in those situations because the keeping duct open is very helpful. And inotrope index, I've just mentioned that if you can monitor on your Cerner charts or the EMRs, it is very helpful because if you calculate the inotrope score, which is for each inotrope, there is a number given, multiplied by the dose, and that you can add on. That gives you a longitudinal view about how much inotropic support you are giving, right? And that is helpful, and the calculators are available online. Coming to the low vascular resistance and what are the factors contributing to that. Vasodilatation, SIRS, NAC, medications, etc., all of it. Enlarged vascular bed with a PDA or arteriovenous malformation, Galen malformation, giant hemangiomas, etc. Hypovolemia, that is about the capillary leak, hemorrhage, etc. All of this can cause low vascular resistance. And we know low vascular resistance, what does it do? It causes diastolic hypotension. There is another way of looking at, you can also see on your screens the variability of your the plethysmograph. So how is it moving, the intraarterial blood pressure, the graph, and that can tell you about the variability and whether the child will respond to the fluids or not. So I think we know that the diastolic hypotension, liberal volume replacement, if there is a loss, particularly in the abdominal wall defects or blood loss, is very helpful. Acute hemorrhage, no option, we transfuse. We try to, as I said, to avoid inotropes if there is a hypovolemia, because that is not good. If we have to use the agent, vasopressors are around, and we tend to use the epinephrine or norepinephrine, depending on what is the associated underlying condition. Hemodynamically significant PDA, conservative treatment, medical treatment, device, surgical, as the opportunities arise and what your practice is. SIRS, volume replacement with other vasopressors, can get you out of the situation. Now, when it comes to the systolic and diastolic hypotension, we are in a bad place. And I think no matter what the experience is, no matter where we are, we do sweat when a baby is having combined systolic diastolic hypotension. This is one place. If you have the opportunity of doing the bedside functional echo, it is extremely valuable because then you can objectively target your therapy to what you want to do. Profound hypotension, think as a warm shock and give volume and drugs to increase the SVR. When there is a LV dysfunction also, epinephrine would help you, and consider hydrocortisone early. And the reason is that sometimes there is an end organ resistance or the receptor resistance to the inotropes. In these situations, whether it is sepsis, whether it is SIRS, whether it's a baby with a high lactate or acidosis, that resistance of the receptors can be reversed by giving the hydrocortisone early, and hence the same inotrope or vasopressors you are giving start acting on the baby. So giving that sooner in this situation can help you getting out. So let's talk about the specific conditions in the next 5-7 minutes. So what are the principles of management in specific neonatal conditions? We talked about the preterm baby, right? First 24, 48 hours, the baby is transitioning from the intrauterine to extrauterine life. And just pause and see, intrauterine, the pump is against a low vascular resistance of placenta. What is the pressure in placenta? Maybe about 5 millimeters of mercury. Baby comes out, and now we want to maintain a blood pressure we think is right for the baby, okay? Whatever we think, mean blood pressure, maybe the equal to gestational age, very widely used, 24, 25, whatever. But the myocardium is immature, and if there is any additional factor which affects the transition, it can lead to low systemic flow because there could be shunts present, there could be baby on a ventilator, and with a positive intrathoracic pressure, the output goes down further. So in preterm babies, The primary problem is not the systemic vascular resistance, but it is a low systemic blood flow. And in these situations, an early monitoring and input in form of a low-dose dobutamine is a very good option to get the baby out and before it goes into the uncompensated states of shock. So if you look at the x-axis, which is the flow, the y-axis, again, you would have seen this many times, is the blood pressure. So again, 4 quadrants, your flow is normal, your blood pressure is normal, clearly we don't need to do anything. When the flow is low and the blood pressure is low, I think we all would agree we have to do something. And starting with the inotrope, and if required, a vasopressor as the condition B, if the baby is septic, you might want to add that. If your flow is normal and blood pressure is low, there is no urgency to treat this baby. Please monitor and review it in an hour, 2 hours time. Baby, majority of times they improve in this situation. But if the flow is low and the blood pressure is normal, very commonly you will see on your bedside that is a preterm baby who came in and baby's blood pressure is fine, and suddenly the lactate starts building up, the baby starts going down, there is a mottling, and next you see the baby is suddenly dipping down. The problem is here because here the flow was low, and because of the body's responses, the blood pressure was maintained for a while, which arbitrarily we think the baby is doing fine, but the underlying problem we have not solved, which is a low flow. So hence, if there is a possibility of doing a bedside echoes in these particular situations, I think it is a practice. But again, if it is a change in practice to your local unit, you might want to see it a different way. So this is a cartoon from my good friend, cardiologist, David from Newcastle. And here, this is the principle that we don't need to squeeze and tighten, right? Because it causes the low blood pressure and low cardiac output. But the principles of treatment should be relax and dilate. And that improves your cardiac output in preterm babies and reverses the situation very well. So I think the thinking has to change of targeting not the blood pressure, but looking at the flow and the blood pressure together. Can we advance the slide, please? Thank you. Okay, thank you. Now, let's change to elevated pulmonary artery pressure, right? Elevated pulmonary artery pressure, right to left shunting, okay? That is atrial septum, PDA, or intrapulmonary at any of the levels it can happen. Cardiac dysfunction, it can happen right ventricle or the left ventricle, right? If there's a clinically significant pulmonary hypertension, we know it presents with hypoxia, hypoperfusion, hypotension, acidosis, and the clinical outcomes are affected with the morbidity and the mortality not in favor. So there was some discussion yesterday about the pulmonary venous hypertension, the capillary wedge pressure, and how should we be looking into it in our management. So 2 principles here. If you have a normal or low pulmonary capillary wedge pressure, that means your shunting across the duct is right to left, your shunting across the PFO is right to left, right? That is classical pulmonary hypertension. And in that classical pulmonary hypertension, we know it's a precapillary disorder. We get the echocardiographic clues because of dilated right heart, left ventricle is not, and elevated PVR in these situations. In this case, pulmonary vasodilators will work, right? Take a different situation, post-capillary pulmonary hypertension or elevated pulmonary capillary wedge pressure that is reflected with the left atrial pressure. You see here in situations with the BPD-associated pulmonary hypertension, in post-capillary physiology, if the left ventricular failure, structural defects of mitral valve or aortic valve, there the clues are that their shunting across the duct will be right to left, but across the atria will be left to right on the echo, okay? Echo clues are by dilated left ventricle and increased left atrial and diastolic pressure. These things should be a pointer that this baby doesn't require a pulmonary vasodilator. If you give that, you make it things worse, and hence systemic and not pulmonary vasodilators are required here to improve the left ventricular output, which will reverse the situation, okay? Hey, could you advance the slide again, please? Thank you. Thank you. Hypoxic ischemic encephalopathy and the cardiac hemodynamics. Just a word about that. You look at the hypoxia ischemia, it does cause myocardial ischemia, and this is with the reduced myocardial perfusion, and hence the contractility of the heart decreases. Myocardial ischemia, in addition, causes the affected papillary muscle and also subendocardial, right? This will lead to the poor RV function, okay? In addition, even if the baby is 36 weeker, immaturity of the neonatal myocardium can affect it, and hypoxia acidosis also affects it. That will lead to decreased pulmonary flow, decreased LV filling, and reduction in the cerebral and the systemic flow, right? We see it very commonly. So unfortunately, when you look at all the trials of cooling, you would see that 40% of them had pulmonary hypertension, but objectively they were not assessed about the severity of pulmonary hypertension. And I think the cardiac function assessment in babies with the HIE and intervention could further improve the outcome with therapeutic hypothermia. It has not been proven yet, but there is possibly a hypothesis that could be generated there. I think, yeah. HIE, approach to the management. Mild transient myocardial ischemia is usually asymptomatic, and most of the times it will recover on its own. But if there's a moderate or severe hypoxia ischemia, we know there is significant cardiac injury. And if you do the TROP-I in these babies, you'll find sky high. And if you do that, you would be convinced that there is a significant damage to that. And it causes hypotension in about 2/3 of the cases, approximately. In these babies, you see it's behaving just like the myocarditis or cardiomyopathy, where the heart is affected and the contractility is not good. Giving more volume is not good because you will make the things worse. So the drugs to treat the hypotension, avoiding tachycardia is important because you don't want to increase the oxygen consumption, okay? So in addition, when you do the active cooling and during rewarming, the physiology changes, right? And hence, I'll touch upon if there is associated pulmonary hypertension, what can you do? I think it is not working. Yeah, thank you. So pulmonary venous hypertension, very common with the LV systolic dysfunction in babies with the HIE. So what are diagnostic clues? In these babies, you would see pulmonary edema on the X-ray. There will be a left ventricular systolic dysfunction on the echo, and there will be left to right atrial shunting, as I said to you just now, right? Hypothermia-induced vasoconstriction may also cause left ventricular wall stress and exacerbate dysfunction. So hypothermia, if you are inducing, that is also an additive effect. As I mentioned, prostaglandin can maintain ductal patency and augment post-ductal cardiac output, and INO should be used with caution in these babies, and hence it is important to realize that. So this is just a brief table on managing perfusion in babies with HIE. So there are 4 scenarios here. One is, this is the LV or RV dysfunction on its own, or there is a pulmonary hypertension with a normal cardiac function. Third is pulmonary hypertension with a right ventricular dysfunction, or pulmonary hypertension with a left ventricular dysfunction. This is kind of not written in stone, but this is kind of a guide that we use in these babies. If there is primary dysfunction, we use dobutamine first line, epinephrine second line. With the PPHN, epinephrine low dose, add on dobutamine if required, or milrinone as the case may be, but with caution in HIE, as I said, never do the loading, and prostaglandin E if the PDA is restrictive to offload the right ventricle. With RV dysfunction, the prostaglandin comes in early, and with the LV dysfunction, you don't need because you want to avoid tachycardia and improve the cardiac output. So if there is a pressure resistance hypotension, then we know that there is a receptor downregulation and there could be adrenal insufficiency. And a low dose hydrocortisone in these babies at 1 to 2 milligram per kg every 8 or 12 hours could be helpful in these babies in the first couple of days' time. And then you might want to just withdraw it. Next. Touch upon the neonatal sepsis. And we know the sepsis presents you with a warm and a cold shock. That's just a schema. If you have a warm shock, then a high cardiac output, low PVR, warm extremities. Cold shock, hypodynamic circulation, that is low cardiac output, and cold extremities. Yeah. We know about the abnormal vasoregulation in these babies. And again, 2 by 2 here, you look at the hypodynamic circulation. Here is the blood pressure. Here is a central blood flow. So here you look at If the low flow and normal or high pressures, that is a cold shock, right? Low flow, low pressure, we know it's a cold shock. Normal or high flow, again, warm shock, and then normal or a high flow with a low pressure is a warm shock. So clearly, by doing the echo and looking at the PVR, at SVR, you can know, looking at the diastolic blood pressure and the cardiac function, that what are you dealing with, right? These are situations where require a very urgency, and depending on what the underlying problem is, you require a fluid, you want an inotrope, you want a pressor, that you need to escalate it. So a guideline on the neonatal shock. This is what has been now suggested as a guideline for the management of these babies with a shock, and is widely adopted. If you have for initial resuscitation, no questions, fluid bolus 20 per kg and repeat if required. You never go wrong. Inotrope, cold shock, epinephrine or dopamine. Again, dopamine could have a place, but it can increase the oxygen demand. Warm shock, norepinephrine, as a first line. Hydrocortisone, if it's a catecholamine-resistant shock, you can add hydrocortisone, as I've just said it. Cold shock with a normal blood pressure, milrinone. Our experience with levosimendan is not much, but it has been suggested. Cold shock with a low blood pressure, norepinephrine, milrinone, levosimendan. Warm shock, vasopressin comes in early. And fluid inotrope, vasopressor, vasodilator. And in refractory cases, you can even go for an ECMO. So this is kind of a schema and the escalation of the drugs or the first-line drugs that could be used in these babies. So to conclude, for the cardiovascular management, the journey so far has been quite difficult. And as I say, one protocol might not work because the babies are different, but a physiology-based approach, or when you collect the information and process and look at the objectivity and give it, it might work much better. Which inotrope? I think the broad guide is that dobutamine for inotropy, low-dose epinephrine for vasopressor, adrenaline first line in the term and after 48, 72 hours in the preterm, because if it's associated with the sepsis. Volume, again, the practice of giving multiple times volume in babies who are not well with the circulation is not a good practice. Except for the septic shock, in other situations, if you have given 10 mils per kg of a fluid bolus, maybe another one. After that, you need to really justify why do you want to give the volume. Okay. Hydrocortisone if it's a pressor resistance. Clearly, we need the evidence. And next. Yeah, so I think it's stuck there. Let's talk about just the key points as the last slide. Low flow and hypotension, we know is associated with a worse outcome. Different inotropes have different effects on the flow and blood pressure. Non-responders have a bad outcome. And identify the cause and select inotrope based on what you want to achieve. Systematic approach is the way forward. I think I cannot overstress, and I'm a convert. I must say that for the last 20 years, doing the functional echoes now, that if a baby is sick with a circulatory problem, probably I feel handcuffed if there is no echo on the bedside. So these are the indications where it is justified, at least, to use the echocardiography. Next. Thank you very much for your attention. I'm sorry it's slightly overrun, but it's a very big topic. The subsequent slides online you will find for the evidence. So far it is there. Feel free to have a look at it. But because of time, I have not touched upon what the evidence is at the moment. Thank you very much for your attention.